jugular cannulation in pediatric population. Here you have to know few landmark. Medial and the lateral head of sternocleidomastoid mastoid. This forms a triangle. This triangle is very important because your jugular vein is at the apex of the triangle. Next comes the mastoid process and the external jugular vein. This external jugular vein is very important in the posterior approach to the internal jugular vein. And you have the clavicle and the sternal notch, which helps in the needle direction. Another important landmark which is required in children is the nipple. Here you have to nipple. This is very important from the direction point of the needle. Your clavicle, sternum and the nipple. Here you can see the two heads and the internal jugular ear, and the syringe is pointed towards the ipsilateral nipple. Here another important thing is you cannot rotate the head too much like what you do when adult, which can distort your venous anatomy. Here you can see the medial and lateral head of the sternocleidomastoid, and you can see the clavicle, and this is the sternum. This is the sternal notch and this is the lateral head. This point is the mandible and you have the mastoid. This is the external jugular vein, which is 1 cm to the lateral head of sternocleidomastoid. Now this is the jugular and this is the carotid, which comes from the apex. Now to have the different axis, this is the subclavian vein joining with intrajugular vein into the superior vena cava. This is the high anterior approach. This is the posterior approach, just 1 cm lateral to external jugular, and this is the supraclavicular approach to the jugular vein. And the most common approach which you use is the at the apex of the triangle. Here you go at the level of sternal notch. You point towards the sternal notch, and this is the middle approach where you cannulate at the apex of the triangle. And finally you can have a subclavicular approach to the jugular vein or the subclavian. These are all the different approach with the anatomy of the jugular vein. Here you can see the skin being retracted, so old and taut. Now the jugular vein is being located, the needle is being removed. You can see the blood coming out. Now you will insert the guide wire inside. The guide wire is being inserted. Whenever you insert the guide wire, you have to look at the ECG for arrhythmias, and also you have to listen to the tone. Now as the guide wire is inserted, the cannula is taken out. Now you pass a dilator. Usually you make a small nick in the neck so that the dilator is inserted, but the dilator is used for enlarging the skin and subcutaneous part. You should not enlarge the vein. Then the cannula that is being inserted inside the guide wire, the dilator is removed. Now cannula is inserted and the guide wire is removed outside. Now you have to aspirate and flush. You will connect a 10 cm or you aspirate. See, now you aspirate and there should be free flow of blood which comes in, and it has to be fixed properly. That is very important. And here you can see the jugular vein ending little low. Here it is just below the cavo-atrial junction, and here you can see at the tip at a slightly higher junction.